wanted to talk to you a little bit about some basics of supported communication. So often when I'm working with people with aphasia, supported communication is something that I'm using without even thinking about it, because it really has had to become so second nature. But I recognize that that's not the case for everyone, and some people might have no idea what I'm talking about when I say supported communication. So I thought we'd start from the beginning. Um, okay. Um, so for today, I figured we'd talk about why do we need supported communication and who benefits? What tools do we need? What are some strategies we can use? Where can you learn more if this is not enough? And hopefully we'll have some time for questions. So thinking about why do we need supported communication strategies? If you look at this picture, you'll see a person using a wheelchair, and they're also using a ramp with their wheelchair. We're quite used to seeing this type of supported physical strategy. And so we're used to seeing these physical access ramps. But what about communication access? What do we have to support communication? Well, we have something called communication ramps. And this is really what the heart of supported communication gets at, is providing these abilities for people with communication challenges to be able to participate in their everyday. So just like physical access ramps have helped not only people who use wheelchairs, but people who might be mobility challenged or people who are pushing a stroller, communication ramps can really support everyone's understanding and ability to communicate with each other. And so on this slide, I do have the physical access ramp symbol, but also the communication access symbol. You might not be familiar with this symbol, but I'm hoping that with some of my work, you'll see it a lot more often. And really, when people post this communication access symbol, it means that they know how to use supported communication strategies and how to help people with communication challenges. So when we think about what tools you need for supported communication, it doesn't have to be complicated. Paper and marker are really the best tools. Usually I prefer white paper with a black marker because it has the strongest contrast, but really use what you have on hand. So when we think about communication strategies, there's kind of 5 things that we can talk about. One of them is talking, which we're probably the most familiar with. Another one is writing, drawing, using gestures, and then we can also augment our communication with external aids. So when we're talking, we're really focusing on getting the message into someone else. So we want to make sure that we're doing something so that other people can understand us. One of the biggest things we can do is slow down. I recognize the irony of that as I'm probably talking really quickly in this presentation. But we can also add pauses. We can simplify sentences. And we can use good prosody and intonation because this carries meaning. So instead of just talking like a really flat person, you just add some prosody and intonation. You probably already naturally do that. And then when we're talking, what can we do to get the message out? So what can we do to make sure that the person we're communicating with can get their message out to us? We can ask them questions. We can allow them time to respond. And really being patient and getting comfortable with silence is something that is really important with supported communication when you're relying on just talking. So if only talking is not enough for the person you're communicating with, which with people with aphasia, it often is not, we can add another strategy. So we can talk about writing. When we're talking about getting the message in, so what we can do to make sure that someone is understanding our message, we compare our talking with written words. Usually we only want to write keywords, and we want to use large, bold writing. You also want to think about your client's visual field. So if I'm sitting here like this and writing, and you're sitting across from me, you're probably not going to see what I'm writing or be able to read it upside down. So think about sitting beside each other so that you can see writing, Or if you're really talented, like some speech therapists I know, you might be able to write upside down and face someone across the table that way. Um, but again, writing isn't necessary for everyone. It's something we can add in when the talking is not enough. So how we can help people get their message out in writing is we can provide them written options. So we could say, do you want apple, orange, or pineapple juice? And we might write down those options. We can have a page that just says yes and no, and the person can point. We can also model the use of writing or really encourage someone to write. If they're trying to get a message out, they don't have to write a full sentence or even a full word. Just writing letters, parts of words, or parts of sentences can help you work together to understand what message they're trying to get out. One thing to note is that make sure that if you are using writing, each person has their own pen so that you're not kind of fighting over it or taking away an opportunity for someone to communicate. Just going to take a drink here. If writing is not quite getting it, or if people have trouble with writing words, drawing is awesome. If you're drawing while you're writing, it can slow down your rate. People say that a picture is worth 1,000 words. So if you're using pictures and words, hopefully the message is getting across. Images can also help to simplify really abstract or difficult concepts. And with people with aphasia, they really communicate in concrete concepts. Things that are present for them right there in the moment are what's easier for them to communicate about. But things like abstract concepts like pain can be harder. Drawing doesn't have to be cumbersome. You do not have to be an artist. Whenever I encourage people to draw, they're like, oh, no, I'm not good. But I'm like, can you draw a stick figure? Then you're good. That's all you need to be able to do. And so when you're encouraging other people to try and draw, to explain what they're doing, you can use drawing while you're doing that and just remind them it doesn't have to be pretty, it just has to have a message. Finally, you'll see I'm probably talking a lot with my hands. I like to use gestures, and it's something that people do naturally. But sometimes people with aphasia or other communication disorders forget about using gestures, or maybe don't have access to that part of their brain to be able to use gestures anymore. So what we can do if we're trying to get a message in is use everything to bring your conversation to life. Pointing counts as a gesture. Shaking your head counts as a gesture. So really just using these pieces of communication can help. Um, if you're really not good at gesturing, consider trying to join a group that does some, I'm thinking Pictionary, but that's for drawing. That's not the right word. I'm trying to think of what it is for charades. There we go.
Charades.
Charades. So even practicing charades with your friends is a great way. Thank you, Brett. Like one word movie. When we're trying to get people to get their message out, really encouraging them to point to things, encouraging them to show you or act out what they're trying to say. I had a really great conversation with one of my clients once, and he just couldn't get the words out. But he was able to show me. He stood up and he went like this, like he was pushing. We were able to figure out he took his dogs for a walk in a stroller that day. Um, so really just encouraging people to try. Finally, there's external aids that can help us. So really to either get the message into someone or get the message out, I love using things that we have on hand. So if you're talking about a date, maybe having a calendar there. If you're talking about traveling or going somewhere, having some maps available. If you're talking about family, having access to family photos is amazing. Thankfully, most of us have a computer in our pockets in our phone nowadays, so we can use Google. We can use anything to really help us express ourselves or to show other people. Um, you might also come across people who use alternative augmentative communication or AAC devices. These can be low or high tech, it can be as low tech as this yes and no symbol that I have at the top, or it can be a simple page printed out that people point to, or they might even have an app on their iPad or smartphone that helps them communicate. So if someone does have one of these devices, really encourage them to use it to talk about topics or reference information. A lot of people with these devices have information stored already. So they might have pre-programmed things that they can tell you. And also, sometimes typing can be a little bit different than writing for people. It's more about recognizing the letters as opposed to actually having to reproduce them. So sometimes using some typing can help to get communication out as well. If you need more, there is training available. I would encourage everyone to try the Aphasia Institute e-learning module. It takes about an hour and it's completely free. And it just does give you a little bit of practice with that supported communication. I'm also finishing my Train the Trainer course in October, so I'll be able to offer supported communication training to people in Saskatchewan in person or virtually if that's something that you are interested in or wanting more of. I have some references there that I used, and I think we should have time for questions.
Carlee, thank you so much for sharing. Like, I love that stuff's popping up here.
Ooh, we got a poll. How fun.
Oh yeah, cool. Like, I love how you just went through in like 15 minutes some really practical and tangible approaches that we can all use in our clinical practice. And I think we'll try and kind of summarize some of that and put it out in the newsletter a little bit too. And I wonder, would you maybe consider sharing your slides?
Yeah, I think Ashley already has a copy,
Okay.
just in case of technical difficulties. So feel free to use the information there, or if you need help with anything, just email me, let me know.
Okay.
I actually love getting emails, so please feel free to reach out, anyone on the call.
And when the supported communication, supported conversation, like the train the trainer that you're taking, like
Mhm.
what is required by sites to be able to either become a trainer or have you come and train?
Yeah, so to become a trainer, there are various courses that you take through the Aphasia Institute in Toronto. And so I'm in the process of working through those right now. So if someone else wanted to become a trainer, that is what I would recommend. If you wanted me to come, shoot me an email and we'll figure it out.
Okay.
I think would be the easiest answer for right now. Yeah.
Yeah, there is some online training in supported communication from aphasia. So institute, so we can put that on the newsletter too. But does anyone have any other questions or?
Sarah put one in the chat there.
Let's see.
Oh yeah, the e-learning, the self-directed e-learning for supported communication. Thanks, Sarah.
Thank you, Sarah.
I'll just chime in and say too, because I'm going to be talking about some of the best practice guidelines, and it actually is in our Canadian Stroke best practice guideline that anyone working with people with stroke, so anyone on our team, multidisciplinary team, ideally should have some continuing education in working with people with aphasia. So yes, please, Carlee, teach us all.
Yeah, and I mean, really, I think the easiest thing to do would be to go to that link that Sarah put in, do the free 1 hour training. Again, it's free, it's 1 hour. I think most of us can make that work. And it has amazing information in there. So I would definitely encourage you to do that if other training is not feasible. And it's not like you have to do the whole hour at once. You can split it up over however long you like.
And it's free. You have to set up an account, but then it's free.
Yeah, you got it. And you get a nice certificate after that you can print and show everyone.
Or just
Yeah.
email it to Carlee. She loves emails.
Yes, I would be very proud of you. For
Uh,
family members of people with aphasia, that's a great question. And I think that, a lot of the times we focus on the person with aphasia and forget that aphasia is a family problem. It's not an individual problem. Um, I do know that the Aphasia Institute, I'm going to keep plugging them because they're kind of our best resource right now. So they do have information for family members of people with aphasia on their website. They have like different pamphlets and booklets that you can access as well to share with any of your clients or anything like that. Um, and then I think another thing I would recommend is just if you are working with family members of people with aphasia, checking in on their well-being, checking in on if they have enough supports and if they have um, some time away from their situation that they're living in, because it can be really hard. And we know there's a lot of caregiver burnout. So just kind of trying to check in with them and making sure that they have resources that they need would be amazing and I think would make a huge difference.
And no promises, but we might try and work with Carlee when we're doing some of our site visits to maybe bring her along, that she can do some of the training with interprofessional practice staff and nurses and physicians. So again, no promises, but that's what we're kind of chatting about, trying to get some of the real stuff in your hometown, so it makes it kind of easier and a bit more engaging when you're person to person.
Yeah.
Yeah, absolutely. And I have some really fun role-playing scenarios and things that we can do. So
who doesn't love role playing? No, that sounds great, Carlee. Man, and also Carlee has like so many good ideas, and she's, sometimes looking for participants or places that can try some of her ideas. So we might be shoulder tapping you guys in the future, but
yeah. Or if you have ideas about aphasia and research that you want to talk about, new ideas are great too. So I'm happy to collaborate.
okay. Keep putting questions in the chat if you have them, but we are going to move on.
Oh, no, I have a question first.
Your hand's up. Sorry, Sarah. Sorry,
guys.
Sarah,
Hi.
sorry.
I'm putting you on the spot a little here, Carlee, but I'm a physiotherapist. Anytime I've worked with someone who has a communication challenge, I always think, there's two sides to the situation where I'm like, I need to communicate for my therapy, right? And I've been fortunate to have wonderful SLPs, and you get these tips, and you shared so many of them with us today. But then my head goes to, is there anything I can be doing in my rehab session that can support their recovery or their communication learning journey? So any tips from that lens of things?
Absolutely. Yeah. I think I'm going to kind of break aphasia down into two groups. One group that does really well with understanding, and if you have someone who does really well with understanding and it's mostly the verbal output that's hard for them, it can be a little easier to have a conversation sometimes. So even, maybe you're practicing walking down the hall, talking to them about, how is your dog doing at home? Um, just any really questions that you can ask them to get them to produce an answer is going to be really good practice. If you have someone who's on the other side, maybe having more trouble with understanding, but they're spilling words out left, right, and center, maybe taking the time to, while you're doing some exercises, matching words to the actions that you're doing so that they're kind of gaining a little bit more understanding, and can match those words to the action. That might be something that's more meaningful for someone who has trouble understanding and then you're not really able to have a conversation or maybe ask questions about as much, is something that I would recommend. I'm sure there are other things that I'll think of later, but off the
I
top of
love
my head.
that. I love that, the word matching for the receptive aphasia. And if anyone here has tricks that they use, please throw them in the chat. And as you come up with more, Carlee, please share, and we'll be sure to get them out to people.
Yeah, for sure.
Awesome.
And I think too, one thing that really, I think communication comes down to is building that relationship. So the more time you spend on building that relationship and getting to know each other, the more the person's going to feel comfortable trying and communicating. So I would recommend just really trying to get to know your patients and spending time with them, which is so hard when we are so crunched for time and so overworked, but something to try.
And Carlee,
Awesome.
there is recovery with aphasia, right?
Absolutely, yes. I think, much like a lot of things, we see a big chunk of recovery right at the beginning. And then recovery does tend to slow down, but it doesn't stop. So you might not notice those gains as quickly as time moves on, but it doesn't mean that there aren't gains to be made.
Thank you for sharing, Carlee. And yeah, hey, thanks, Carlee. Do you know if there's any research that shows whether or not supported communication itself is therapeutic?
That's a really great question. I want to say that it's therapeutic. Whether there is like a research article I can point to, I'd have to think about that. But I do think that it's therapeutic because you are working on communication. You're working on strengthening how someone is able to communicate. And so I do believe that it is therapeutic and does improve people's ability to communicate. It might not improve their verbal ability to communicate, which is what a lot of people focus on, but it does improve communication.
Okay, Carlee, Sarah, I can tell that you're like pretty excited to get your presentation going.
No, it was more so I was nervous. I was nervous. I didn't mean to like take over the screen share there, but I was like, is this gonna work? I'm not a fan of Teams. My computer is not a fan of Teams.
Not like Teams. I know Ashley's not a fan of Teams anyways, but we are gonna let you introduce yourself.
Yes, please.
Sarah is one of the OG Coffee and Cases hosts. But yeah, I'm just gonna let you take it away and share your knowledge.
You bet. Thank you. So like Ruth said, I was fortunate enough to be part of our team that developed and launched the first round of Coffee and Cases. And so it's just thrilling to see it still running. And so a great big thank you to oh man, I really dislike Teams, guys. I can't see you at all when I share my screen. So, I mean, Ruth, you'll have to interrupt me if something goes awry here, because when I'm in full share mode, I can't see anything.
You bet.
Okay, so I'm a physiotherapist by clinical training. I worked for over 10 years, specialized in neuro rehab. I then went into research. So I'm at the University of Saskatchewan, and we're thrilled to have Carlee as one of our newer SLP colleagues. And yeah, I just love Coffee and Cases. So thanks for being here, guys. Thanks, Ashley, Ruth, and Brett for keeping it going. I'm going to talk about the most recent release of the Canadian Stroke Best Practice Guidelines. So late last year, the module for rehab and recovery was released. And it's now actually called Rehabilitation, Recovery, and Community Participation. So one of the biggest updates is that they reorganized things and they wanted it to align more with ICF terminology. So we added in that concept of participation and also just staying true to rehab at its core, or by definition, that we're doing all these interventions to enhance participation in meaningful life tasks. So yeah, the 7th edition has recently been out. It's rearranged. And there's now 3 units. So the unit 1's more about developing our health systems and that shared flow and responsibility of who should be doing what when, or what we should have to be delivering best practice. And then there's a functional module and then a participation module. So I'm going to talk about the key components of rehab and recovery from a mobility standpoint, and then I'll emphasize some of the key updates. Feel free to pop questions in the chat at any time as they come up. And I just want to set the context here. So rehabilitation, yes, we have rehabilitation units. We have specialized rehabilitation in Saskatchewan. We have our tertiary hospitals. So there's rehab as a place, but really we're talking about rehabilitation as a process here. So rehab is an ongoing process, not just a destination, and it's to support lifelong recovery post-stroke. And if you keep that in mind, I want you to reflect on wherever you are in the province, whatever setting you work in within our healthcare system, whenever you see people with regards to how soon their stroke was. So across all those contexts, we all actually have a role in rehabilitation and recovery. So if you reflect on, well, what do you think your role is? I can say from the guidelines that everyone has a role in increasing mobility and movement opportunities. So not just our PTs and OTs. Yes, we'll do the specialized training, the goal-specific training for specific functional tasks, but our life, our days have 24 hours. And the research is really supporting that we have to start breaking up sedentary behavior. So as soon as someone's medically stable, I'll come to some parameters in that acute phase shortly, but we all really have that role in trying to get people sitting upright, leaning forward from their chair or their wheelchair or their bed, even trying to do a few sit to stands. If you have some ambulatory participants, if you can help them go for a walk in between their therapy sessions, or even walking to whatever their next destination is, all of that adds up as its own separate contributor in addition to therapy time to enhancing recovery and outcomes. The other thing we all have a role in is education and health promotion. So we all talk about stroke and their impairments or what's happening next. But the guidelines are showing that we should all also be assessing, what do you know about your stroke? How is your sleep? Are you currently active? Because even if it's not in our skill set to address those, it is within our role and responsibility and in the best interest of our the people we work with, their recovery, is trying to get them to the supports to address that. So being aware, this is sort of the last point on the screen, is being aware of the resources kind of upstream and downstream that you can refer them to. And we all have a role in advocating and supporting that they're getting access or have at least been offered access to this information and to rehabilitation, regardless of their next step. So, often it's easy to think, if you're in acute care, you have people who qualify for rehab, they'll go on to inpatient rehab, maybe they'll get a referral for outpatient rehab. But really, we should be thinking about what's the next step for everybody. And that is more emphasized in our new guidelines. So we all have a role in supporting rehab and recovery. It's a lifelong process post-stroke. There's critical windows where we want that intense rehabilitation training, but gains are important, and we can see them even after the 6-month window. And the health-related lifestyle behaviors have one of the biggest influence on brain health and how resilient the brain is as someone who has had a stroke is aging. Okay, so the key things that affect recovery remain the same with this update of the guideline. We're just getting more evidence and higher quality evidence. So really timing Earlier is better, with the caveat that if someone had a severe stroke, we don't want to be doing prolonged intense rehab in the 24 to 48 hours post-stroke. But if they've had a minimal stroke, it's okay. Or if they're minimally impaired from their stroke, it's more okay. And of course, if they're medically stable, we want opportunities to break up sedentary behavior. So timing matters, dosage matters. So now when we're talking about that rehabilitation training, that task-specific, goal-oriented training, how hard we challenge people and how long they're able to train is really influencing the long-term outcomes. So we're getting more studies that are looking at the follow-up period, and it's not enough to just have a 30-minute session, right? Ideally, we need to be challenging them for those 30 minutes within their sessions, and that should be multiple times a week over multiple weeks, and then given a transition program so that they stay active afterwards if we want to maximize outcomes. So timing, dosage, intensity, and specificity of our training matters. Minimizing sedentary behavior. So yes, I know fatigue is an issue, and balancing other therapies is an issue if someone's in that inpatient setting. But really, what we don't want to see happening is they work hard for their 1 to 2 hours of getting therapy, and then they're doing nothing for the other 22 to 23 hours. And another update in the guideline is they're advocating for trying to get structured aerobic training or aquatic exercise or group programs in throughout the day to try and supplement the one-on-one therapy time. I mentioned already the importance of supporting, screening, asking, supporting, and connecting health behavior. So not just physical activity, stopping negative health behaviors, which our stroke prevention teams are amazing at, like smoking and drinking, but also sleep. So some new recommendations in the guideline about sleep and fatigue, and looking at those separate of depression, not just as a side effect of depression. And this is an actual statement. Overall, individuals should engage in training that is meaningful, engaging, so active engagement. It's repetitive, progressed, adapted, task-specific, and goal-oriented to enhance our motor outcomes as well as sensory motor function. So that goes across the entire body. If you're OT, PT, rec therapist, and I know I'm missing others out there, exercise therapist, this is a cross-cutting recommendation. So it goes for the upper limb, dressing, driving, changing, as well as balance, mobilities, transfer, return to work. Dosage matters, task specificity matters, and then the environments we're preparing these individuals to perform the functional tasks in also matters. So hopefully you guys are in agreement with me that everyone has a role in rehab and recovery. And if you're questioning it, or if you're questioning how you can enaction your role, please throw that in the chat, because we know there's guidelines, and then there's actually getting the guidelines into practice. And just because we have the guidelines doesn't necessarily mean we can do the other change practice. So I think that's why this community is so great, is sharing tips and tricks, but also challenges and resources, and just navigating it together. So yeah, think about rehab as more than a destination. Ideally, rehab and recovery can start in acute. I know there's lots of competing challenges and often resource challenges, but you don't have to feel like you need expertise in inpatient neuro rehab to do benefit and start someone on that rehab and recovery journey. If you have any role in referrals or advocacy, keep in mind that the guidelines are strongly supporting that everybody should get access to rehab, and not just those that are getting referred to our inpatient rehab. And hopefully we can build a system that mirrors what our acute stroke services have done, where they have these well set up hubs and spokes. So ideally, our Saskatoon City Hospital and Wascana Rehab are in the future well-resourced to continue to serve more effectively as a provincial support for your local teams. And I've heard of lots of people making connections through Coffee and Cases. Just keep reaching out to them, because we know, we know everyone just has the person post-stroke's best interest in mind. So I mentioned timing in the acute phase. So there are studies that's showing really, sorry, I'm getting ahead of myself. That's my next slide. I think I hit the point already that early mobility and movement opportunities should be made available, and ideally by all members of the team, not just our therapists. We do still want to get the right people, so there is some suggested intake criteria into our inpatient rehab units. But I put the actual statement here so that we can see they're telling us that we can get all people into rehab wherever the setting is. So including inpatient, outpatient, community programs, or home-based programs. And then we all have that role in trying to connect people to their local therapy or even their local community programs, because we're going to start screening and asking more about health-related lifestyle behaviors, and linking people to those supports for the brain health factor. This is what I was talking about. So research, the AVERT trial, looked at early post-stroke training, and they found that if people had a moderate to severe stroke and they were exerting themselves for prolonged periods, like over 10 to 15 minute periods within that hyperacute phase, then their outcomes were worse. But what they did find is outcomes were better if they had more frequent movement. So I just know sometimes that trial gets misinterpreted where we're like, oh no, we're not supposed to move people in the first 3 days post-stroke. Keep in mind that avoiding prolonged exertion is very different than bed rest. And there's lots of movement that can happen within a bed, right? So bed mobility, simple exercises like leg pumps, bridges, even getting them to try and assist in self-rolling, coming in for your nursing check and just asking them to sit up off the back of the bed. I know so much is going on. It's sensory overload. There's fatigue. They just had a bleed in their brain. But tiny little bits of movement are going to add up to enhance recovery outcomes. So really the messaging now is that all stroke patients should commence mobilization, including out-of-bed activities, within 48 hours of stroke, unless they're medically unstable or there's another contradiction happening there. If we're talking about that task-specific traditional rehab, not as a unit, because it can happen in many settings, what we need to focus on is the high volumes of challenging task practice. We want it to be goal-directed and function-oriented. So yes, they may have spasticity, and perhaps the spasticity in their limbs preventing them from engaging in their task, but we still want to think of the rest of the body's role in that task. We still want to be challenging their sitting balance. We want to be practicing weight shifts and reaching and whatever functional level they're at while we're working with the multidisciplinary team to manage. So we don't want to be coming in and using such precious therapy time just to passively stretch, unless that's the only option. There's always caveats to this, but really you want to come in, you want to prioritize your time for function first training. A little bit of compensation is a-okay. It's how our body's learning, as long as we're not damaging the joints or neglecting skin and musculoskeletal integrity. We want to see some errors and we want to see some challenge, because we really want to be prioritizing that active engagement for driving the brain reshaping. And this last point is what I was mentioning earlier. Where possible, we want this rehab training to be supplemented with opportunities for movement, maybe some structured aerobic exercise, and just breaking up sedentary behavior. These are the actual statements themselves, but they're just examples to show it's not just one statement. It's coming up over and over again across different types of approaches and in different sections of the guideline, how important it is to emphasize high volumes of challenging task-specific practice. This shows on the left-hand side, upper limb, right-hand side, lower limb, balance, gait, some of our other mobility. And you can see even within these sections, they're mirroring each other, right? So the first 2 points are exactly the same. Individuals should engage in training that is meaningful, engaging, repetitive, progressively adapted, task-specific, goal-oriented. Then the other points are getting to this balancing, when do we integrate the more affected limbs versus compensating by using the least affected limbs. And it is always a balance. But in those early phases, we want to try and encourage whole body movement. And then the lower points on the screen, again, are just to show that it's about the overall approach. So if we're taking that function first, challenging, task-specific approach, there's so many different ways to get there. And with some patients, it works best with FES. Other patients, you can try more strength training, or you need to use adaptive equipment. The reality is that often you're using multiple of those different interventions to get that challenging task practice. And with upper limb, just be mindful of hemiplegic shoulder pain. So this is a new recommendation, and I think it's kind of exciting that we have high quality evidence here. So if you're working on someone and you're trying to engage the upper limb or retrain upper limb tasks, we actually have research now to show that if you restrain the trunk, or if you think about trunk posturing, so even taking a tensor and respectfully strapping them to the back of their wheelchair or their chair while you're doing some upper limb movements, that can enhance recovery, because the compensatory drive to take the path of least resistance and move your trunk instead of moving that hemiplegic arm is so strong that it can prevent the learning with the actual arm. So they're saying retraining trunk control itself can improve the effects of your upper limb outcomes, and also using trunk restraints can help to stabilize the trunk so you can actually really get into that upper limb training. Keep in mind, you then have to progress to doing the whole task practice, because most movements in the real world need both that integration of the upper limb and the trunk. But if you're starting early and you want to prioritize some of your session for the upper limb, just reflect on how much is that trunk cheating and what can you do about it. I'm almost done here, so we'll have some time for questions. Another new recommendation, it's not new that we should be doing aerobic exercise, and it's not new that we should be doing aquatic exercise. It's just new evidence. So now we have higher quality evidence to emphasize how important it is to increase movement opportunities. So aerobic exercise, I've said multiple times, but even in that absence of having, to go to a bike or go to a pool and set up a structured 10 or 15-minute therapy session, make it simple. Just think of how can I decrease sedentary behavior, and what role do we all have in that. Fatigue, I slipped this in earlier as well. So it's all of our job to screen, especially for things that go undetected, such as mood. But we're now seeing more research of the primary fatigue that's happening post-stroke. And so just being mindful that there's not necessarily a correlation between the severity of stroke and the severity of fatigue. And some of those strategies, if anyone here works with people with MS, some of those strategies for central fatigue management, we might want to consider applying to people post stroke, because we're learning more about how that fatigue exists, and it's not dependent on having depression, and it's not dependent on severity post-stroke. So in summary, taking a function first, task-specific approach matters. Intensity and dosage should remain your top priority. So they're getting therapy, but start to think on what's the quality of therapy. If you're not monitoring how hard they're working or how much they did, how are you going to progress it? So maybe caring less about, oh, should I use this approach or that approach? Think, I can sprinkle anything on to augment this movement in this practice, but did I give them enough time under training? If you're in our acute care settings, please share your creative ways of getting people moving. I can actually send out some bed mobility examples. There's just, lots of safe ways we can get people moving outside of that traditional sit to stand or standing and walking. If you're focusing on the upper limb, don't forget about that trunk. And I know there's many OTs out there laughing at me where they're like, oh, how could I forget about the trunk? But we now have evidence to show how important it is on the upper limb outcomes. Try to supplement, try to get people into rehab. Let's start there, right? Regardless of the setting, we want all people post-stroke within, ideally within the 3 months post-stroke to be getting the opportunity to train. And then if they are getting that in an inpatient setting, see if you can supplement it with opportunities for aerobic training. We want to think about the whole person and not just what we're trying to improve right now, but how that skill is going to allow them to participate in their meaningful life tasks down the road. So getting people practicing in those environments or practicing those tasks, or at least thinking about that transition approach. And that's all I have to say for now. I always have more to say.
Oh, thank you so much for sharing, Sarah. It is like, well, does anyone have any questions or comments for Sarah or Carlee?
Or tips to share. How do you get your people moving, or afternoon walk club? Nice, Ruth.
Yeah, we haven't been always very consistent, but there was a couple of PTs that were pretty excited about it and would send up some, like a PTA up to take whoever wanted to go for a walk at 2 o'clock. They would just kind of do the loop up on our unit. But it is really good. Like, I'm for sure at fault for going in to see a patient and they're like, I'm too tired. So you're like, okay.
I just need to assess this. Can you sit up?
Yeah.
And them sitting up may have nothing to do with your assessment, but you have just, it's like giving them a pill. You've just given them a recovery window, right? So we all have a role in that.
Yeah, no, that's a super good reminder. Oh, thanks, Caprice. We will be posting the presentation, so tell your friends that if they didn't come today, they missed a really good one.
Oh, I love it. And I'm just going to plant a little teaser here. I don't have the details yet, guys. But if you're a PT or an OT, we are going to be launching some workshops. Anyone's welcome to join, but we're targeting PTs and OTs. Carlee's going to come and give some tips. Exercise therapists, rec therapists can all come. But what we're wanting to do is host the workshop. We can have some travel bursaries. So if you're a rural therapist, we can cover your travel to come to the workshop in Saskatoon, or if you're in the south of the province, we'll do one in Regina. So I'll get that information and make sure it gets circulated in multiple channels, but through Coffee and Cases will be one. And I see Sarah is asking, there has been some discussion of how trunk resistance contradicts previous NDT-based training. I like how you provided some more insight into this. However, many people would be interested in understanding these studies better. Yeah, we can do a detailed deep dive into that. The key thing is balancing. It's just like with walking and bracing, right? It's like, when do you do what? If someone is always initiating a movement with their trunk and you want to focus on that dissociation, like scapular moves on thorax or even just arm movement, even in the absence of the bracing, just like stabilizing with the other arm or giving them an external cue, like pushing back against the wall and getting lots of reps in first so that you're igniting the pathways from the arm to the brain to say, hey, use me. The research in neuroscience is showing if you're always initiating with the trunk, it actually is inhibiting the arm. Our brain likes the path of least resistance. But yeah, we can do a deep dive on that. Great question, Sarah. Ooh, how long do you expect post-stroke fatigue to last? It is a beast. It can come on 6 months post-stroke. It can come on earlier, and we don't really know. And I think one of the challenges is that should be celebrated about this guidelines. It's really the first time where they're like, oh, post-stroke fatigue is its own impairment. Like it used to just be thought of as a secondary neurological impairment or a composite impairment from all these other impairments, but they're like, no, there's something centrally going on. So we're going to learn more about it.
And I would say, clinically, just to add to that as well, I know people with aphasia who experience stroke fatigue, and they are sometimes 10 years down the road, and they still feel like they need to take an afternoon nap because the fatigue just hits them. Or they still plan all of their appointments in the morning because they know that they're going to be too tired to process the information properly in the afternoon. So I don't know if there really is necessarily an endpoint to the stroke fatigue that we can pinpoint at this time, unfortunately.
But people, like, it seems so silly, especially when you're in it. Like I remember this with the frontline provider being so annoyed with research where you're just like, duh. And so the good news is that it's officially been identified as a thing. So we're gonna get more research and understanding about it. Yeah. I like Sandra's point. Well, we cover travel back home too, or do they have to stay? I think the better solution is find another therapist and take them back with you so we can fill any of those rural and remote vacancies.
Oh, Sarah. Okay, you guys, we're just wrapping up. I want to thank Carlee. I want to thank Sarah for coming and sharing their expertise, and just kind of helping ignite the passion around aphasia and movement and best practices. And these things will be posted. There's going to be a newsletter, and I am going to put in the chat because I can't share my screen, Ashley. Yeah. Melfort. You crazy kids, our newest stroke center are last year's TNK champs, the fiscal year's TNK champs at 53 minutes. Unbelievable. Coming in hot on the tail is PA at 56 minutes. So you guys, awesome job. Way to go. We will see you next month for our ABI. Last one of the year. Yeah. ABI, and then we're gonna be looking for suggestions for starting up again in September, October. So again, happy May long weekend. Stay warm out there, stay dry, and we'll see you in a month. Bye. Bye.